I'm gonna.
Okay, go ahead.
Yes. All right. Good afternoon, everyone. Mitchell Walker, pastor of the Church Street Cumberland Presbyterian Church in America, president of the Greater Huntsville Interdenominational Ministerial Fellowship, and I am so pleased today. I am just really excited and happy to have with us our special guest, who is one of the voices, not only in the state, but in the nation, in regard to what we're going to talk about today. That's Dr. Karen Landers. She is the Assistant State Health Officer and District Health Officer, and she has other titles as well, and we're just delighted to have her. I know a little bit about her because she has been to our Greater Huntsville Interdenominational Ministerial Fellowship meeting in person, and she's been online with us a couple of times. But I'm going to let her tell you a little bit about herself. Dr. Landers, good to have you with us today.
Well, thank you, Dr. Walker. And I also want to say to your group and to you how much I appreciate, as a member of the Alabama Department of Public Health, the forward-thinking leadership that your team has put forth during this entire pandemic. I well recall that at the very early part of this, that you were involved in seeing some of the planning and discussions that we were doing with the city of Huntsville and the Madison County leadership. And then very much after that, you brought in the faith-based community, and I actually came over and did a live meeting with a lot of your team members at that time. And I do think that that has had a lot of influence, specifically in Madison County, on the outcomes there, because you have been providing that message through your team and through your leadership. So thank you so much. Well, my background is, as I said before we got on the video today, I have been a physician. I'm in my 44th year as a physician. Now, I know I don't look it, but anyway.
No, 44 years. The kid can't
I'm in my 44th year as a physician. I did graduate from medical school very early, so that does account for part of that. I am a career public health officer and have worked 38 years with the Alabama Department of Public Health. And I guess as the situation would have it, one of my career-long interests has been in emerging infectious diseases. So I've had some experience in working in various emerging infectious diseases, as well as training through various situations in the United States. I have done some training through programs at Fort Detrick, Maryland, through programs at Aberdeen Proving Ground, programs at CDC, as well as more recently with the National Ebola Training Center several years ago when it was stood up, and actually did some work with them in the past year or so with some training at Oak Ridge, and again, just a lifelong or career-long interest in emerging infectious diseases. And rolling all that into a ball has been pretty helpful in the situation that we now face. And while this is unprecedented, we have to go back and look at all of these experiences and add that information to it. So that's really my background as a physician and how I wound up doing what I'm doing right now in COVID-19. I also have a career-long interest and have been involved in tuberculosis control for the Alabama Department of Public Health. And many of we physicians who work TB control nationwide have been brought into this work due to our understanding of respiratory droplet spread infections, etc. So again, that's how I got involved in this.
You've been a busy lady, I tell you. And busier now, I'm sure. Yeah, and tell us a little bit about your faith experience. I know one of the things that I remember when you came to speak to our ministers, our clergy group, is that you talked about your faith. You're not only a doctor, but you're also a person of faith.
Well, absolutely. Well, I think that the greatest healer, of course, is Jesus Christ. That is the healer, and that's where we have to, as Christians, put our trust in a higher power, especially in a time such as this. And while we all stumble in our life and in our faith journey, what has ultimately guided me as a physician has been a focus on doing unto others as I would have done unto me. Now, I'm not a minister, so I can't quote
like you were preaching now.
But just to say that my goal as a physician, my goal as a person is to treat other people the way I would want to be treated, whether that is in a personal situation or whether that's in a professional situation, where I would bring to the patient to try to do for the patient the way I would want to be treated if I were on the other side as a patient. And when we started out in this, and really many times during the day, I have to just stop and ask God what he really wants me to do here, because this is not for the faint of heart at this time. It's not for the faint of heart for any of us. And I think, but by the grace of God, I would have faltered long ago. But I think that we as Christians need to model the behavior that we are committed to a higher power, and that higher power gives us knowledge to be able to carry out the work while we're here on this earth. So that's really my way of looking at it. And sometimes when I am down and out on this, I think about some of the things that you actually said early on, and you have been a great inspiration to me, as well as working with some other ministers, including our own ministerial group in Northwest Alabama, and just reminding them that COVID-19 is not the end all of what we're talking about right now. We have a future that's past COVID-19, and we need to focus on that while we're carrying out this mission.
It's so important to maintain hope, and in spite of the fact of all that we don't know. We know a lot, but we hear a lot, those of us who are not the experts in the field, but and sometimes it can be overwhelming and stressful, and so it's always good to know that we have someone and something beyond this present experience to place our faith in. So can you kind of explain to us today what is COVID-19, coronavirus, pandemic? What are we really battling in this unseen predicament?
What we're really talking about is the COVID-19 illness is caused by a virus called the SARS-CoV-2. And the way this virus got its name, it's actually a member of a family of viruses called coronaviruses. And they're called corona because if you look at the viral structure, there are really some little spikes on the virus that makes it look like a crown. And of course, corona actually meaning crown. So the coronaviruses, again, are a family of viruses. And at least 4 of the viruses in the coronavirus family are very common respiratory viruses in persons, and they circulate primarily in the winter, but can circulate year-round. So really, we're talking about 7 viruses in this family. And of these 7 viruses, there are 3 that are just particularly bad actors. One of them is actually the SARS, the SARS, the SARS virus that appeared in the early 2000s. And we thought that one was pretty bad, but we really never experienced any more severe difficulty in the United States. I think, there were probably a few hundred cases, and I don't remember the data because it's been wiped out by this new data. But again, the SARS virus, this virus is very similar to SARS, and that's how it got to be named SARS-CoV-2. And then there is a virus in the family called the MERS, the Middle Eastern virus, the Middle Eastern respiratory virus. And this has primarily been seen along the Arabian Peninsula, Saudi Arabia, in that particular area of the Middle East. So we have this virus. It is a member of the family of coronaviruses. It was first discovered in China back in the winter of 2019. And again, we started hearing a lot about it in December, but certainly in January, we really got this information about how this virus was continuing to circulate in China and how it was causing severe illness, primarily a syndrome of cough and fever and shortness of breath. And subsequently, as we have seen, this virus has gone on to actually provide another subset of symptoms, even though fever, cough, shortness of breath has been in about half of patients. Of the hundreds of patients I have talked to, if you look at the other percentage, we've now seen patients have headache, chills, loss of taste and smell, a new onset loss of taste and smell, sore throat, muscle aches, and some gastrointestinal symptoms. And again, these are still overall a smaller percentage of the overall symptomatology, but we have learned more about this. As this virus came into the United States, probably before February of 2020, we now know that, but the first case in the United States was actually described in late February in Washington State. And then here we are today with the hundreds of thousands of cases, and of course in Alabama now with about 19,000 or so cases. It changes, and of course we had a little trouble with our dashboard. But again, this is a virus. It is a member of a family of viruses. It is really the worst actor in that family, probably, and it is transmitted, we still believe, based on all the information we have, through respiratory droplets. In other words, speaking, coughing, singing, sneezing, respiratory droplets. So as I've said from the beginning about respiratory droplets, we still have to remember that respiratory droplets really can only go about 6 feet. Now, I do know we've seen some studies with severe coughing and sneezing that they can, get out in the air a lot further. But these respiratory droplets are breathed in by persons, or from a rare instance or an unusual instance, a frequently touched surface. We touch a surface, then we touch our nose, we touch our mouth, we touch our eyes, and get the mucous membrane infected with that virus, and then subsequently develop the symptoms and signs that I talked about. It takes between 2 and 14 days, with an average of probably overall around 7 days. We see a lot of people have onset of symptoms between 5 and 10 days, but probably overall around 7 days to develop the actual symptoms once we have been infected with the virus. So that's what's called the incubation period, and that's how we wound up with the 14-day quarantine. So again, a bad virus that infects the respiratory symptom, the respiratory system, that has a broad range of symptoms that can occur with just about any virus, and tends to be not so severe in younger people, but persons with comorbid conditions such as heart disease, lung disease, kidney disease, liver disease, diabetes, or immunosuppression. Any age group that has these conditions can have a worse outcome, and also particularly severe in persons over 65 or persons that are in long-term care.
Now, I think you said to us in one of the other settings that there are some blood types that are make a person more susceptible. Can you talk about that?
Yes, early on, and still we think that this could be the case. We have looked at the scientific data, which comes out every day. There's something new in science every day. Some of the articles turn out to be really good, and some of them turn out to be not as well studied. But we do believe that persons who have type A blood might be more likely to have worse outcomes than persons with type O blood. And we also believe, based upon some early information, that while men are a little bit more affected than women overall by the severity of the virus, part of that is probably related to the ACE2 receptors. So we're still a little early on in looking at the science, but there are probably some other factors outside of just the overall infectivity and the potentially underlying conditions. There could be these other factors that are still being studied.
So can a person have the virus or have had the virus and not have been shown any symptoms, or been not displayed any of the symptoms that you mentioned?
Yes, and of course, really we describe that in one category, which is called asymptomatic. And what I say about asymptomatic is persons never have any symptoms. That means they never felt bad. They never had any of these symptoms. They don't recall anything, and so they are in the asymptomatic category. Now, the percent of infected persons that are asymptomatic and spreading has really been debated, and depending on what study you read, you can see varying percentages. I have seen one study that indicated that persons that are infected with the SARS-CoV-2, that there could be up to a quarter of these persons infected that may not show any symptoms. That seems a bit high to me, and I've looked at some other information that is really more in the 10% or so range. But I think that is still an area to be studied and to be determined. But the overall message has to be that recognizing that asymptomatic spread can occur, and that's the reason that we talk about our preventive measures for this. Now, we also talked about pre-symptomatic, and I've used that term, and some people have said, well, what does that really mean?
Yeah, I was going to ask you about that.
Right. And actually, that's something I think you and I talked a little bit about that, because we have had several conversations. And this is really, like you can see with other diseases, such as influenza, for example. And this is not influenza, but it has some characteristics that are similar. And right now, we doctors just have to have something to compare things to. But the pre-symptomatic person is a person that is infected, and they are going to develop symptoms, but they are already transmitting the virus. And that occurs with some other viral illnesses. So that persons that are pre-symptomatic are probably pretty contagious for a couple of days before they actually go on to develop their symptoms. So again, we go back to our preventive measures that we'll talk about as we go along.
Okay. So should persons get tested? I mean, you know, if someone could have had the virus and didn't display any of the symptoms, what about testing, and how available is testing, and if there are costs to testing, how available is that here in Huntsville and Madison County?
Okay, well, we'll talk about testing here. Well, first of all, who should be tested? And I do remind people that while asymptomatic people can be spreading the virus, one thing that I also say about that is if you're asymptomatic and you just get tested at one point in time, that's literally just a snapshot. That's just like taking a Polaroid. You know, that's what it looks like today, but it can change tomorrow. However, we do have a criteria that I'm very pleased that we were able to expand out our criteria as we develop more testing capacity in the state of Alabama. Overall, who should be tested for SARS-CoV-2? Well, persons who should be tested, who are in the categories to be tested, would be, first of all, persons who have the symptoms that we talked about earlier. And we say fever or cough or shortness of breath, or 2 or more of the other symptoms that I outlined, such as headache, sore throat, loss of taste or smell, recent onset loss of taste or smell, chills, and I mentioned fever earlier, gastrointestinal symptoms, muscle aches, 2 or more of those symptoms with any of the other combination. Now, those, again, persons who are symptomatic should be tested. Then the second group that really should be tested overall is we also focus on persons who are over 65 or persons who have underlying health problems or persons that live in congregate settings such as perhaps long-term care or group homes or, you know, situations of incarceration, something of that nature. Those are all persons that might need to be tested even if they're asymptomatic. Again, some of that depends on the situation. But let's talk about asymptomatic persons who might want to get tested. Well, we have categories of asymptomatic persons. Again, first of all, persons with heart disease, as I mentioned, lung disease, kidney disease, liver disease, diabetes, or immunosuppression. And these are all persons that can avail themselves of testing if their doctor wishes for them to be tested, or with the Bureau of Clinical Labs. The reason being that we have picked up people with those kinds of diseases that are underlying, that are asymptomatic and have a positive test. Now, you mentioned cost, and you also mentioned availability. Huntsville, if we're talking about Huntsville, Madison County, again, being, I believe, currently the 3rd largest county in the state of Alabama, has really had a very large testing capacity through either the Huntsville hospital system or some of the private physicians' offices or some of the urgent cares there. And of course, Huntsville Hospital has its fever flu clinic, and that's just one of their clinics that's available for testing. And then, of course, persons who have to go to the emergency room for another reason. I tell people, don't go to the emergency room to get tested. Go to the emergency room if you're sick after you've talked to your doctor or the emergency room, but don't go there just to be tested.
Sure.
But again, getting back to capacity in Huntsville has been pretty high. The community of Huntsville, Madison County has carried out thousands and thousands of tests. Now, as far as the Bureau of Clinical Laboratories, the Alabama Department of Public Health, we have not specifically had a specimen collection site in Huntsville because Huntsville has had a huge footprint for testing. And also, I understand they've gone out into communities with their hospital bus and done some testing. However, what we do remind people is testing through the Bureau of Clinical Laboratories, if there's a situation where persons need to be tested and they have no insurance coverage, any test sent to the Bureau of Clinical Laboratories and any physician, nurse practitioner, urgent care can send, or hospital can send their labs to us. Our testing is free of charge. And we do the same testing. We do PCR, and it is free of charge. The surrounding counties, we have done a lot of health department testing because, again, a smaller medical community.
Okay. Okay, so if a person is 65 plus and they have one of those other issues that you named, health conditions, should we go to see about getting tested? I mean, should we, even though we may not have displayed any symptoms, just to know? I've had that question asked by some of those before today. I want to know, should they go and get tested?
Well, again, I think we're really, as I mentioned, we talk about that snapshot in time. And I generally tell people to speak with your physician or your healthcare provider to see whether or not they want you to have an asymptomatic test. Because, again, it's literally that Polaroid. But if persons feel that they do need to be tested asymptomatically, then I would access one of the resources there in the Huntsville-Madison County community. But be reminded, again, that's that Polaroid. That's that one shot in time.
Sure.
Just because you're negative doesn't mean you remain negative.
Yeah. And what about the antibodies test? We've heard something about that. So how foolproof is that? How reliable?
Actually, didn't mean to talk over you. You've heard me talk about that about every Friday, I think.
Yes, I have.
And I have actually had a great interest in this since the beginning of it. And I'm fortunate to know some physicians who are very well-respected virologists, and we've talked about this. And also the Infectious Disease Society of America has what's called a primer on this, which basically is a little 8-page paper that talks about antibody testing. Now, early on, the antibody testing that was available when this first started and even up to recently was not sensitive and it was not specific. And by that, I mean that there was a very high risk of crossover from those other cousin coronaviruses showing false positive testing. And it wasn't specific enough to be able to really pick up whether or not a person was exposed to COVID-19. A lot of antibody tests flooded the market right after COVID-19. And this antibody testing that flooded the market, unfortunately, there were products that, not that they were bad products, but they just didn't have the sensitivity, they didn't have the specificity. And a lot of those have been withdrawn by the FDA, saying that these just really aren't good enough to know. Currently, there is some newer antibody testing out from some very large laboratories, including some laboratories that are affiliated with certain major medical centers. And that antibody testing might be useful from the standpoint of what we call surveillance. And again, individual physicians might order that particular type of antibody testing for their patients. But we still caution, we're not absolutely sure that even if a person has COVID-19, that they will mount an antibody response enough to be measured, and also that that antibody will stick around and provide immunity. So that's sort of still to be determined.
That was the next question. So if you've had the test either knowingly or unknowingly, can you get it again?
Yes, and thank you, and I apologize. I've been talking a lot lately.
Sure.
Before I got on the call with you today, actually, that is something that's being studied, and that's why we are looking at the information on what's called seroprevalence studies to really see if in certain populations, in certain communities, that antibody testing of this very high quality could be done and could be looked at to see what the overall seroprevalence, again, with these very high quality tests could be. But also, we will have to be monitoring as a scientific community nationwide and worldwide to see whether or not having had coronavirus, COVID-19, will actually be providing any long-term immunity. So that's still to be determined. It's a very, very hot topic. But the overall message that I provide to patients, and again, I talk to a lot of patients myself, is that right now, antibody testing is really not very useful unless it's in a seroprevalence situation or it's one of these extremely high quality antibody tests that are being done by these very large major laboratories. Certainly the finger prick antibody test is not very helpful right now. I mean, it's a test that is very confusing to people. And absolutely, antibody testing has no role in diagnostics whatsoever.
Okay. Well, I know we have persons on that are watching right now, or we'll watch later, that are outside of our greater Huntsville, Madison County, Tennessee Valley, North Alabama community. But certainly those of us who are here are interested in knowing how are we trending in the state of Alabama, and particularly here in the Huntsville, Madison County community.
Well, overall, and this is something that I think we have to watch all the time, and that's why, you know, that everyone's trying to keep their finger on the pulse of this. Overall, Alabama has not been going down. If you look at the state of Alabama, you can see that there are individual places in Alabama that still are seeing a rise, and then you see other counties in Alabama that are kind of flattening out, and then you see some counties that are starting to go down in terms of numbers. And I caution people like to mention the word hotspot, but I caution that, you know, you're really just one event or one entity away from having a lot more cases. So we can't let our guard down statewide. Plus, we also know that people don't just stay in one county. I mean, you know, even though I carry out all the preventive measures, I was actually in Huntsville early this morning, and now I'm back over in Sheffield, and then I'll be back in Huntsville. And so I'm in different places myself, even with carrying out all the preventive measures. But as far as overall in the state of Alabama, we are certainly at a level where COVID-19 is still circulating, and that's why we need to stay absolutely in the mindset to reduce this virus.
You know, just as you were talking about your mobility, everyone is like that, being quite mobile. So what are we doing about contact tracing? What do we need to be doing about that?
Okay. Well, that's a very good question. And actually, if you look on our website, you will see a little graphic on contact tracing. You can actually see what contact tracing is all about. And case investigation and contact tracing, you know, I always tell everybody this is something we do in public health in notifiable diseases that have a public health intervention. You know, for example, tuberculosis control. Again, I mentioned I'm a TB doctor, and we do case investigation and contact tracing all the time, especially in that particular condition. I just recently had a new case of TB reported to me right before we got on the call today. So case investigation really involves when we have a positive test reported to us. And let me just back up and say that every laboratory that does COVID-19 testing is required by law to report their positive test to the Alabama Department of Public Health. And we really request that report come in electronically within 4 hours. But as you may know, we've had a little trouble with our electronic system because there have been so many tests coming in, both positive and negative, which is good, and we want both results. So the test is required to be reported to us. Once we receive the test report through our electronic portal, regardless of whether it's done by clinical lab, commercial labs, or of course we enter our own as the Bureau of Clinical Laboratories, then we also have healthcare providers to fill out what's called a report card, which is a little brief one page. It's actually not even one page, but it's a click, 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 and that opens up a notifiable disease investigation. So we have a case investigation where one of our staff members speaks to the person and finds out where this person has been, really where they've been over the last number of days. We like to really back up and see where they've been for the last 14 days. So find out where they've been. Have they been just at home? If they've been at home, who's been coming in and out of their house? And of course, we have been in the safer at home mode. But who have they been around? Have they been at work? If they have been at work, where do they work? Who do they work with as far as their close contacts? In other words, not necessarily if you work in a massive plant, but who do you work around? Who are the people you work around? Do you drive back and forth to work with somebody? Who are your household members, intimate partners, close contacts? And we're really looking at people that spend time more than 15 minutes, a consistent time, less than 6 feet apart. And then finally, since we're talking about churches and other groups, have you been to church recently? I mean, many churches have been doing their ministry online. But obviously, have you been to a physical building? Have you been to a church or another religious gathering? Or have you been to a more recent gathering, such as the peaceful protest? Have you been to the protests? I mean, we need to know these things. We can't contact trace people that are in a large crowd in a protest, but we likely can be in touch with churches and other entities and find out more about, what's been going on there, so that contacts can be identified. Who are the contacts? Are those persons sick? Are they symptomatic? Or if they're asymptomatic, then information and education can be given to them regarding possible COVID incubation period, preventive measures.
One of the things that you have talked about in one of the other settings was about, like, for example, church is doing a registration so that you kind of know who's there on what Sunday in case there's something come up. You kind of talk about that, or would you encourage the churches? That's something that some churches have a pattern of doing that anyway. But for those of us who may not, what would you say to us? Should we do that going forward?
Well, actually, and you and I discussed that just a little bit, and some other churches have asked me about it, and I know that actually in some other states, people are doing that. And I think it's a great idea. It would really help us out were there to be a case in a church or entity if that information were available. And again, contact tracing is a confidential matter, so that if a person has a case in their church, I mean, Alabama Department of Public Health is not going to go to the church and say, Mr. So-and-so or Miss So-and-so is the person who had COVID, but rather to make the leader or leaders of that church congregation or business or other entity aware that, we did have a case in a certain time. And of course, the case would tell us the information regarding who they've been around. So yes, I think listing, I actually had people say that they are doing that. And this is another way as we work with various entities. Again, businesses know who work there. Most people know who their congregations are, but as you have a dual situation there where you have some of your ministry online, and then you'll at some point have an open ministry in your faith-based house of worship, it would really be something that would help our contact tracers.
You talked about the possible exposure in large group settings, for example, in the protests that have been held. But also, what about in, for example, Memorial Day weekend? And, that's kind of the beginning of some of the opening back up. So have you seen any trends changing since Memorial Day weekend, or graduation exercises, or even with the protests?
Well, of course, we've done a lot more testing over the last several weeks, and even after Memorial Day, we're kind of coming up on 2 weeks. Right, I think we're right at about 2 weeks from Memorial Day, but also some places are having in-person graduations, and we are aware that there was a graduation exercise where a person that was COVID-19 positive went to that exercise. Now, again, in that particular exercise outside, the risk of transmission was low, and at this point in time, we don't have an indication that there was an epidemiologic link, or in other words, subsequent transmission. But talking about Memorial Day, right at the moment, we've not really seen specific events that we can point to and say absolutely that was part of this. But we do know that smaller gatherings or smaller numbers of people getting together, that we did have persons that got together around that time. I actually had some persons that got together on Mother's Day, which was a few weeks before that, and had some COVID-19 spread within those particular situations. So I think as everything opens back up, one message, and I know we've talked about this so much, is that people become weary. I don't have anything really new to tell you to prevent this right now. I'm still giving you that same message that we talked about. And people become weary, and they become really lax about carrying out these measures, because it has gone on already for 3 months, if you will. I mean, that we've really been in the throes of this very, very, very heavily. And I think that is very risky, especially what I've seen over the last few weeks, including Memorial Day. It's very risky, because even if we skated on Memorial Day, well, now we've got the 4th of July coming up.
Yeah, right.
So the more we do, and the larger the groups, and the longer that congregate period, and especially if we're inside, if we're outside, it's a little bit better, but especially if we're inside, then we're just asking for trouble if we do not implement the social distancing, respiratory hygiene, and mask measures, which are all designed to reduce the risk of spread of this virus.
Well, you segue right into my next question about masks. I have masks. I have the disposable mask. I have the cloth mask. Others I know have the more official ones, but the question is, how effective is wearing of masks, either the cloth mask or the disposable mask? And if you're wearing the one or the others, I mean, if you're wearing the cloth mask, how many times should you wear it before you wash it? And the disposable mask, how many times should you wear it, or should you dispose of it immediately after wearing it? And should we continue to do social distancing? And should we continue to wear gloves? I know that it seems like since we are no longer sheltered in place, that there's more relaxing, as you just mentioned, in terms of wearing masks, somewhat in social distancing, wearing gloves, and doing those things. Because at first, people were really, almost everybody had a mask on, it seemed, and many people were wearing gloves, and we were more conscientious about social distancing, and that's still happening. But now that we've opened back up, what should we do? And then I want to move into the church matter, because that's of great significance for all of us, for many of us who are listening today.
Right. Well, again, and you've asked a lot of really good questions. And of course, early on, we didn't have good information regarding whether or not masks were really even needed. But now that we see with more community transmission that wearing the mask can be useful. And we actually have a graphic on our website. You may want to get part of your media team to download it. It really shows like maybe one person wearing a mask, another person not wearing, and we see that there is less and less and less risk. Now, the New England Journal really didn't help me out the other day, because they literally threw in a sentence that said, and they were talking about physicians and nurses wearing N95s, and they just randomly threw in a sentence about, well, lay persons wearing masks may not reduce COVID. That one single sentence, and I thought, well, you're the New England Journal. Unless you have data, just stay with the N95s for doctors and nurses, and don't throw that out there. Because this is the way I look at masks, is that with asymptomatic spreaders or pre-symptomatic spreaders, it is going to reduce that respiratory droplet coming out either through forceful speaking or coughing or sneezing or singing. It's going to reduce those respiratory droplets coming out, not totally, because again, it's not an N95, but it will reduce those droplets coming out, and it will protect other people from your droplets, and it will protect you from other people's droplets. And we also have to remember, of course, I'm a TB doctor, I'm used to an N95, but not everybody is accustomed to wearing a mask. So I remind people that we're going into the summer, but there are reasonable ways, and I'll talk about cloth versus disposable here. There are reasonable ways if you are looking at your mask, for example, that you might find to be helpful. One thing is that if some people are uncomfortable in a mask that has elastic band that you put around your ears, if that really gives you a claustrophobic feeling, then get you a mask that has ties on it, because some people feel more comfortable adjusting the ties. And in addition to that, just reminding that with cloth mask, I tell people, they say, well, what do I do after I wear the cloth mask? Well, sanitize your hands, then put the mask on. And once you have the mask on, as my mother used to say, don't fool with it. Okay, you have it on, don't fool with it. Don't keep putting your hands back and forth, but put the mask on, leave it on for the time that you need to wear the task or wear the mask, then sanitize your hands before you take the mask off. So you've really sanitized before you put it on. Okay. You've done your very best to keep your hands off of it, and then sanitize once you take it off. What I tell people to do with a cloth mask is launder the cloth mask every day. So if you use a cloth mask in your daily activities, and let's say, for example, you are wearing a mask around, and if you go to your car and you're just driving somewhere by yourself, yes, you can sanitize your hands and take your mask off and then sanitize when you put it back on. But when you go home at night, put that cloth mask in the washer and either dry it if, it's drier material. And I really like for people to use cotton masks because I think those are very comfortable, or hang that mask out. So it's good to have more than one. So if you have more than one mask, then use that. Now, you mentioned the disposable mask, and the disposable basically that are out there, and a lot of people have those. And when I tell people, the reason they say they're disposable is that they are disposable, which means that if you're wearing them for a period of time, like if you only wear your mask 4 hours a day, then when you finish wearing it for your 4 hours, you need to dispose of it. Those kinds of masks, and again, I know people have said, well, people recycle N95s. That's a little bit different, and I'm not a huge fan of recycling N95s, but we had to do it a little bit early on in this. Now we've got the mask cleaning systems, and so we've really improved that. But I tell people that if you're going to use a disposable mask, that's a single day item, in my opinion. So if you're going to use it for that day and then dispose of it, because they really are not built for wear and tear, and certainly the cotton fibers in those will become a little bit damp and potentially ball up and be very uncomfortable. So if you're going to use a cloth mask, you can use it for that day and then wash it and have an extra one while that one dries, or if it dries overnight. But I usually tell people have at least a couple of cloth masks. If you feel that it's too tight on your face, get you a mask that has the ties. That's a little easier to work with for some people. Make sure your mask covers your nose and your mouth. I've seen a few people wearing their mask below their nose. That does not work. Yeah. And then finally, if you're going to use the disposable mask, they're really good for a day. Now, people have asked me, how long will the cloth mask work? It really depends on how they look in the washer. In other words, if they start getting frayed and worn, you need to get rid of them. Yeah. But a lot of them you can use for 30 days or longer, just depending on how they're holding up.
Okay. And what about with the disposable mask? I think, as I remember, some of them are like 1 ply or 2 ply, 3 ply. Does it make a difference?
There's been a lot of discussion about that, and early on people were using various, maybe in a cotton mask they were, in having a pocket, and some people were putting a coffee filter in there, or even a HEPA vacuum type filter. And those are not harmful things as long as people are comfortable enough breathing with them. I do make people aware that some of these vacuum cleaner filters have fiberglass in them, so they need to be in a cotton pouch if people are going to use those. And really, if the mask is being provided by a store or a pharmacy or some place of business of that nature, they really should be of a little thicker quality. So if you can get a 2 or 3 ply, that's certainly better. And again, we all know, and I've actually done this myself just to demonstrate things years ago when I actually was training people how to use N95 masks and doing fit testing and just reminding people and showing them the difference with an N95. And, you know, you really do a lot of things where you can't feel the moisture coming out, and you fit it up to your face, as opposed to even a surgical mask or a cloth mask where you can put a mirror in front of you and breathe really hard on the mirror so you actually can see the condensation there. But again, a thicker ply is reasonable. Now, persons who have heart disease or lung disease, where like COPD, where they might feel restricted in a mask, these are persons that need to be very cautious about their social distancing, going out, and also be in situations where it's better to not necessarily go inside buildings and small buildings, and certainly not grocery stores or pharmacies or places like that. If they can avoid that, send their family members to do those errands.
Okay, well, one of the primary reasons that I wanted to talk with you today, all of those things, but also we're part of the church, and there are many who are watching today, pastors and clergy and church leaders who are watching, and some have already started to maybe phasing in, going back to the church building to have worship and activities. And so talk to us about that. I know you can't tell us what to do, but tell us what you kind of advise us as to what we need to be concerned about as we start talking about opening our churches and re-entering again.
Well, that's a very, very good question. And as you know, you've probably seen the information through the Alabama Department of Public Health on one of our flyers related to opening houses of worship, and also aware that the president has said that houses of worship are essential, and also the governor in her guidance wanted to ensure that people could open houses of worship. And what I remind congregations is really you have to look at your individual situation and your individual congregation. And some of the influencers for me is looking at the type of congregation that you have, such as the older population or the more vulnerable population that's in your congregation, and some of the measures that could be taken. For example, if we're going to have live worship service, that older, more vulnerable persons or persons with underlying health problems could have a separate service, or could continue to worship through the online services. Of course, we have to remember that people like me are probably not as computer savvy as some of the younger generation, but online services are an option for the very vulnerable, or separate services from the rest of the congregation where you have a younger, more mobile population and also have children or babies in that. So what I tell people is to look potentially at having separate services for populations. But if you are grouping, or if you are in a situation where you're having a congregation, that grouping people in their family units is reasonable. That's just another way some churches have done this, is to have designated seating for family units. Additionally, at this point in time, I'm not a proponent of bringing back the children's churches and children's groups at the moment. That's just, I'm a pediatrician and also an infection control physician.
Right.
And I think that the more you expand the circle out, the more risk you have. So again, keeping family units together, and then in churches having your seating to allow the social distancing, the 6 feet. And of course, as I saw a minister actually put something online to say, you have to remember that 6 feet is 6 feet all around you, not just 6 feet in front of you, it's 6 feet all around you. So even cordoning off pews or removing chairs, depending on what your structure looks like. And a lot of this guidance is in the ADPH document that was produced after the governor made her announcement. Another important issue, even though it is a lower way to spread COVID-19, is keeping surfaces clean and frequently touched surfaces. And I'm certainly aware that in situations such as churches, it's a good idea to not necessarily have that public water fountain out there anymore for the time being. We really shouldn't have our individual coffee service or donuts, even though I'm sure many people will miss that, but that's
no donuts.
Not a good idea. Not a good idea at the moment. Keeping the restrooms clean and keeping those certainly sanitized, and then really strongly encouraging people, because you're going to be in a building, strongly encouraging people to wear a cloth face covering. Now, one final thing that we've talked about a lot is depending on the structure. Again, you know, some of the churches are extremely large, very high ceilings, and have really great air circulation. And some churches are smaller and might need to ventilate with opening windows or keeping doors open to the extent they can for, you know, safety and other purposes. But just consider your ventilation system within your church. I'm certainly not an environmental engineer, but I think, again, the smaller a building is, I do know this working TB control for my whole career, the smaller the space that people are in and the more opportunity for people to be close together and not be able to maintain that 6 feet or just barely maintaining that 6 feet, there's more risk there for spread of disease. So again, engineering practices that can be put into place. And a lot of this, as I said, I know you've seen the document that is on our website, and it's a very useful document for churches.
So is there some sanitizer that are sanitizing agents that are better than others, and how effective are they on cloth surfaces?
Okay. Well, actually, I had my secretary today listening in on the National Ebola Training Center, who has done a really good discussion about the products to use in this. Now, I guess if there is something that's encouraging is that household cleaning type products used safely, and I always stress safely because we have had an increase in poison control calls where kids have gotten into cleaning products, but household cleaning or janitorial cleaning products used safely and used according to manufacturer's instructions will kill the COVID-19 virus, well, basically the SARS-CoV-2. So again, your janitorial supplies, if you turn it over and it says that it kills influenza, and, you know, kills other bacteria and viruses, it will work. It will work for the coronavirus. So again, household janitorial chemicals that are used for this and the various brands, the chlorine containing the other products. Now, because there has been a shortage of those particular products, actually on the CDC's website related to cleaning, they actually have an expanded list of products that have been considered to be effective for the coronavirus. And I'm really more concerned about surfaces such as, you know, hard surfaces such as electric light switches or, you know, countertops or bench, depending on what your pews are like, you know, bench arm rest. I'm really more concerned about those particular surfaces as being where you could contaminate. As far as cloth surfaces, again, the spray products that could be used that are also safe to use on those surfaces without fading your fabric or causing a problem there. So there are multiple products listed on this, and after we get the link from NETEC, I'll see if we can send that to you. But in the meantime, CDC does have a list, and the EPA has approved some other products to be used.
Okay, well, we'll get to wind down here. I appreciate your time so much. So let me just ask you, one of the things churches are having to consider, as you just mentioned, is whether or not, depending on the size of the congregation and the capacity of the sanctuary or fellowship hall or wherever that gathering might be, of having multiple services or opportunities for people to get together. So after one, should there be a sanitizing before a second group re-enter?
Absolutely. And again, if you're using a common area for multiple services, and again, some churches are using perhaps a chapel for one service and the larger auditorium for another service, either one is going to need to be cleaned and cleaned frequently. But if you are bringing in multiple groups, sanitizing between groups. Absolutely, that is very important. And again, as I mentioned, restrooms, just a little bit, sanitizing those restrooms between groups and keeping those frequently sanitized. COVID-19 is not really a gastrointestinal illness, as we've talked about. It's a respiratory droplet illness, but we do know that restrooms being smaller and, a place that, might have more contamination anyway, we certainly encourage that restrooms and common areas be sanitized between groups and very frequently.
Okay, and what about us singing? Choirs. Can you talk to us about choirs and should choirs use masks, or should we not use choirs and use smaller groups? And when the pastor or minister is preaching, should we be masked? What should we do?
Again, I'm going to go a little bit back to my TB control background and say that right now, as much as all of us enjoy the musical ministry and everything, I hope there aren't music ministers on here, but right now singing probably is not a good activity to undertake. And the reason being, I'll give you a TB example. Laryngeal TB, which again is TB of the upper airway of the larynx, laryngeal TB can be very easily spread from singing. And we've actually, through the years, investigated cases of TB outbreaks in choirs from a person with laryngeal TB. So I think it kind of follows here right now with the COVID-19. The choir's probably not going to be terribly effective if they're 6 feet apart trying to sing and trying to provide a musical offering. So I'm probably leaning a little bit on my personal experience as a TB physician, but I'm telling the persons in the choir that this might be a time for voice rest, and that maybe singing.
Pastor too.
Well, if you're also the soloist, it might be a good idea for voice rest. Now, if someone wants to play a piano or play an organ or play another instrument as a musical offering as an individual or something like that, then that's reasonable. I probably would stay away from the singing right now. Of course, in my church, if I don't sing, the people there are generally very grateful. So, I don't think that singing is a really good idea. One thing I would mention, and you ask about the minister being in the pulpit, again, given the size of the church, if the minister is in the pulpit and he's, I'm looking at thinking of different churches that I've been in, if you're 10 or 15, 25 feet away and you're up on a dais and you're providing a message, then you're pretty socially distanced from people. Once you come down into further close contact, you're not necessarily be able to maintain your 6 feet. So I would keep my mask handy and available. And a lot of that depends. I mean, people see me on the Friday conference in Huntsville and they say, why aren't you wearing your mask? I generally don't like to wear a mask when I'm speaking into a microphone because I do sound a little bit muffled, and some people like for me to be a little bit muffled. But, the reality of it is if you're in a congregation where you're far enough away and you're giving a message, then that's reasonable. But that distance really should be maintained and really should be spread out.
And should people wear masks when they come into church? Because I've heard some say, well, we'll wear a mask when we enter, and then once we're seated, we'll allow people to take their mask off. So should masks be required for the entirety of that time? Well,
again, and I'm going to give you some of my personal opinion based upon, I'm going to go back to TB, and a lot of people say, well, this is not TB. I said, no, but it's a really good reference point for me. And as we talked about earlier about wearing the mask, once you have it on, you need to wear it, really, because once you have it, you come in, you're really coming in from outside. So you're coming in at a little less exposure because you're coming in from outside. But to me, once you have it on, you need to keep it on, because you remember we talked about sanitize before you put the mask on, then put the mask on. You got to sanitize once sanitize before you take the mask off. You got to sanitize again. So I tell people, once you're wearing your mask, just consider that to be part of your attire for the event that you are going to.
Okay. Well, thank you, Dr. Landers. You have been awesome today. Thank you, as you always have been. Thank you for your availability to help us and talk to us about this matter. And because we're challenged, and particularly in the African American community, which our churches are in, that we're challenged because of the numbers that we have that have contracted and the numbers who have deceased. So we're really concerned about not rushing, some of us at least, are not, everybody wants to get back to church, to be among each other. We know we can't do the handshaking, we can't do the hugging, we have to maintain the social distancing, but we also just want to make sure that we keep our community safe as possible, which is one of the reasons why some of us here locally in our Greater Huntsville Interdenominational Ministerial Fellowship have not advocated our members to be a part of the mass protest. Not that we don't believe in it, not that we don't support it, but we're just concerned about persons being out there and then making and being vulnerable and contracting something. Certainly, I think we all know that it's a worthy cause, it's a right agenda, but we've just been concerned and since some of us have not gone back to church yet, we just wanted to be extremely cautious because of so many of the numbers of African Americans who have contracted the disease and also deceased. So, any final word to us today?
Well, I think you have, again, always been on point in your group and your team as very important messengers in the African American community, that we do see the African American community having a higher mortality risk, about 40–45% of our deaths overall in Alabama, between, again, depending on when our data set comes up, in the African American community, and really looking at the comorbid health conditions that are risk factors for the African American community, and in general, some situations and some populations having less access to health care, and then some careers that African American persons are in, putting them more at risk because they have more contact with the public. So I think the influence that you have had and your team has had in the African American community in Huntsville, Madison County, and surrounding has been really a symbol of how a group comes together, synthesizes information, and provides the best leadership for the population that you are serving. And certainly all of us are very, very upset at the loss of the life of Mr. George Floyd. I mean, this was just, there's no excuse for it. This was just not something that any of us can justify. It is something that needs to be addressed, and certainly people have a right to discuss this and to protest peacefully. However, the message that you are providing to your community is that, and I read what you put out and what your team put out yesterday, and it was very inspiring. It was very inspiring that you understand, you recognize, and you are an agent of change. You're also making your community members aware that there are more vulnerabilities in the African American community. There are more health disparities in the African American community, and that if persons become infected and develop this virus and become sick and some of them die, then their voice is not going to be heard, and there's not going to be an opportunity to change something that desperately needs to be changed. So I think that your group has, as a group of physicians, a group of nurses, a group of healthcare providers, I think that the ministerial group in your organization has saved lives. You've already saved lives in your community because of the message that you have continued to spread and the outreach and the forward thinking that continues to go on. And I would just really want to, first of all, thank you for that, and also ask that you continue to stay in touch and we continue to work together. Maybe one good thing that's come out of this is you and I have gotten to know each other,
yes,
but that we continue to work together for the health and well-being of all populations, but also specifically populations that have been underserved.
Yeah. And on that note, I'm wearing orange for a particular reason. I noticed your That's an orange, and I would ask, is that a Tennessee orange or an Auburn orange or a Florida orange or?
I'm from Knoxville, Tennessee, originally.
All right, yay.
Are you from Knoxville?
All right, go Balls, Rocky Top.
Absolutely.
Thank you so very much again. We appreciate you. We pray for you, for your strength, and for your safety as well, and that you'll stay healthy. God bless you. Appreciate you.
Thank you. Thank you, Dr. Walker.
Thank you very much. You have a blessed day and weekend. Thank you.
Thank you. Bye-bye.